Professor Ponseti worked on the Clubfoot for 15 years, from 1945 to 1960, and then he published his detailed work. He studied ankle and subtalar joint movements extensively to know the functional anatomy by cadaver dissection and radiosinometry, and he developed this model of his dissection. And with this radiosinometry, he could recognize the movements of the calcaneonavicular and calcaneocuboid and talonavicular joints with progressive serial casting. So he said with each serial manipulation and casting, there is mobilization of talonavicular joint and subpedal joint. And while you maintain these mobilized joints, they develop progressively bone remodel is maintained in the cast. Similarly, the calcaneocuboid joints also move around the talus when you do the serial manipulation, and progressive remodeling and joints are maintained in the cast. He developed the concept of coupled movement at ankle and peritalar joint, which we call talonavicular, calcaneocuboid, and subtalar joints. He stated the movement that the ankle and subtalar joints are coupled movement, and it is almost impossible to reproduce them independently without affecting the one joint to the other. And this was labeled as the Ponseti basic principles. Because of this interdependence of the tarsal joint movement correction, when adduction with the fulcrum at the talar head simultaneously correct the varus of the heel. I mean to say, when you stabilize the talus here and you correct the deformity from the pronation to the supination and abduction, so you move the forefoot. As you move the forefoot, the talus and other joints also move along the forefoot movement you produce. Therefore, the heel varus and supination of foot will automatically get corrected when entire foot is fully abducted under the talus. So you place it, you stabilize the talus, you move the forefoot. So with forefoot, the midfoot and hindfoot also moves simultaneously, and it corrects the deformity. This is called the basic principle of the method. They have a biological evidence supporting the Ponseti technique. As it is said, the weekly serial manipulation casting and the bone remodel if you maintain the position of the foot after manipulation. The viscoelastic properties of the tissues of the ligaments and the joints, the gene responsible for this clubfoot deformity remain active from 12 weeks to 20th week fetal life, and they last up to 3 to 5 years. It means their gene which produce the clubfoot deformity starting their action from 12 weeks, the second trimester, third trimester, but it continues for the 3 to 5 years. Therefore, whatever the deformity you have corrected has to be maintained with the 3 to 5 years in the braces. And the collagen tissue fibers cell increases in the ligaments as the neonatal age increases. So there is an abundant collagen tissues in the ligaments of infants. They are wavy, very cellular, and could be easily stretched as you weakly stretch these joints. So displaced navicular, cuboid, and cancellous be gradually abducted under the talus without cutting any tarsal ligaments. So this is the concept of, because of the wavy and cellular elements in the tissue, more cellular element, when you stretch, they get stretched. But you should not increase the force so that ligament never be stretched beyond their natural amount of give, but they can be stretched periodically to achieve the optimum result. It means gradually stretching will produce a good effect instead of a sudden movement or overstretch movement, which cause the breaking in the tissues and they produce a problem. And while in the Achilles tendon, it is stated the collagen bundle with a few cells are there, and mostly these are the fibrous tissue there. They are tough. Therefore, the Achilles correction usually required in 67 to 97% clubfoot tenotomy. Supported tenotomy is required. So clubfoot with Pirani score 5, debility 4 usually require a percutaneous tenotomy. So this, by this concept, he stated the major flaw in the Kite methodology was attempt to correct the components of deformity one by one. That is called sequential correction instead of simultaneous correction of the deformity. So in the Kite, he usually stabilized the mid-tarsal joint at the calcaneum level and in the cuboid level, and then they stretch to correct the varus and adduction deformity one by one instead of in as suggested in the Ponseti methodology. These movements are the coupled movements. So when you move the forefoot by stabilizing the talus instead of stabilize the mid-tarsal joint, you stabilize the talus. So when you move the forefoot, the all other joints, midfoot and hindfoot, also get corrected simultaneously. So this is called the coupled movement and the basic principle of the Ponseti. As you in the sequential correction of the kite, the each deformity is corrected. First corrected is the forefoot adduction, then the second correction is the hindfoot adduction, and the third correction was the equinus correction. It means it is a sequential correction, whereas and it produced a breaking in the capsular structures. That's called the kite error. And the procedure it was lengthy and short of the satisfactory results, and significant number of releases do occur with the. So he actually changed the concept from the sequential manipulation to the simultaneous or synchronous movement of the midfoot and the hindfoot as you move the forefoot. And this was the concept, and it gives a good optimum results, very easy to master, requires lesser duration and produce superior results in comparison to other methods, and it gives 90 to 98% successful results. So he also set the goal of the treatment that after the treatment, when treatment is complete, their foot should be normal functional, pain-free, normal looking, planting rate, weight-bearing foot, and the movement should be supple instead of rigidity. No rigidity should be there, and good mobility, and that can be fit in the normal shoes instead of the special shoes we used to give usually in the children when we used to use the methodology of Kite in the olden days. And then is establish the good muscle balance. Usually, a bracing is maintained to in the day and the night time after 3 months, and in the daytime you leave to the peroneum to develop, evertrust to develop, and then this muscle balance power to give a good supple, free mobility and non-functional.